This is the first study I'd like to take and illustrate how to use the program. The apex is at 9 o'clock, and this is the corresponding real-time clip. If I double-click on it, the clip can be enlarged. I also, for example, can make various measurements if I wanted to, which are not related to speckle tracking analysis. For example, if I played this clip frame by frame and identified the end diastolic image, which is right here, I could then measure, for example, the length of the chamber and the corresponding width. And these are the measurements located here. I also could take and measure the area by tracing like so. And this could be used in my 4-chamber view analysis of the size and shape of the 4-chamber view. Here's the corresponding area. To activate the 2D cardiac performance analysis, I have two choices: the adult program or the fetal program. For the adult program, the icons look like this on the screen, whereas for the fetal program, the icons look like this. I simply would click this and this to load the left and right ventricles, and we would then come to the part of the program in which I identify a single cardiac cycle to evaluate. The M mode can be the M mode can be placed perpendicular to the interventricular septum. Here we can see systole and diastole. I could place the M mode parallel to the annulus, like so, or like so. This, for example, is always a little bit cleaner to use the right ventricular annulus. Here we can see systole and diastole. So if I were to drag this, for example, like so, and I watch the clip, I see that this becomes diastole and this is systole. So I would then come here and begin with systole located here and diastole. So I would place my marker in diastole and in diastole, and tap here and here. So this would be my cycle that I'd like to evaluate. Now again, if I place the cursor here, you can see the different M-mode representations. Here it's through the atrial chambers, and in diastole, using the atrial systolic waveform would look like this, or the ventricles would look like so, and again the annulus like so. So we have several choices we can take and use for defining our cardiac cycle. Now we click next. This next step, I will identify the left and right ventricular endocardium. I will place the red dot in the left ventricle at the septal area and the base and the apex. And the system automatically flips the image to have the left ventricle always on the left, apex on the right side. Now, there's a function called quiver, which I would like to take and activate. And you'll see, for example, how the walls are moving. Now, this is very important to try and fine-tune the placement of the dots. And you can see right here, this is the back of the ventricular wall, right at the atrioventricular junction. So I'm happy with this placement. I will now click this and go to diastole. Now this is very important. In the when the heart is located with the apex at 9 or 3 o'clock, this movement right here represents the atrial motion. This is the ventricular motion. So I'm going to take and place my dot right here and here, and I'm just going to adjust it accordingly. And you can see right here, this is the point where the atrial chambers are going this way and the ventricle is going this way. This would be the insertion of the valve leaflet, and right here is the valve leaflet. So now I've identified my left ventricular contour, and we'll now do the right ventricle. Again, I'm using the quiver technique. And here we have placement of the dots. I'll stop the quiver. And that looks like a good contour. I'll take that, put this right here. And this will start the quiver again and see where we place our dots. And this is the back of where the valve inserts like so, and right here. So now I've placed my dots on the screen, and we have now the contours of the right and left ventricle. We see this would represent the left ventricular septal wall, this is the lateral wall, this is the right ventricular septal wall, and the lateral wall. These are the corresponding measurements that are made, or computed I should say, from TomTec analysis. We have endocardial global strain, various lengths, areas, etc. that I've explained in a previous lecture. What I'd like to do now to export the XML file, I'll go up here where it says 1, 2, 3. I click on this, and I will then save it as Apex 9 o'clock as an XML file like so. Let's examine these graphics. This represents the global strain of the right and left ventricles. And as you can see, as the curve comes down, you may identify in systole at the in-between point of where the curve is, but it may be more of a guess than an actual accurate placement. To do the accurate placement, what I've learned is that if you look at the 0 on the DADT of the right and left ventricles and see where the lines cross, for example, the purple line representing the right ventricle is here and the left ventricle is here, I would simply adjust the cursor to the left ventricle, which is this point right here, and that would be my end systole for the left ventricle, and the same thing where it crosses here for the right ventricle. So this is a very useful tool to identify end systole based upon the DADT change of the area. Now let's look at some of these other buttons to see what they represent on the screen. Here we have end systole. This shows me the clip at end systole, the clip at end diastole. What I'm now going to do is show you some of the features of the display of the heart after the analysis has been completed. So the first thing I want to do is increase the size of the image. This icon gives me a choice of different types of displays. This is the 4-chamber view with no overlay of the speckle tracking analysis. This represents the movement of the pixels. Here we can see, for example, if I stop this, we can observe in diastole, and you can see how this portion of the ventricular wall moves all the way to this point in systole. So this is a nice way to look at the tracking that is occurring. The other displays, we have just the graphic showing the endocardium as it moves in systole and diastole. This represents a strain diagram. If the colors change dramatically from blue to red or orange, that would be the area of abnormal strain. This is a vector analysis, and you get a sense of how the muscle may be moving and actually rotating. For example, this is a ventrist. Often investigators have suggested that the ventricle has a certain torsion as it moves. You'll see the apex is moving in this direction, the base is in this direction. This is not very quantifiable, but also interesting to view. Here we have then the corresponding clip with the vector and the strain display. Now, if I wanted to go back and adjust my contour, I could go to my end systole and adjust it accordingly. Once I do that, I also have to adjust the diastolic component. For example, let's say that I just adjust this just for the moment like so. I then click the icon to start the analysis, and it now forces me to also readjust the diastolic. Now this is the new analysis. Let's just change this back to this. However, if I go to D and I adjust the diastolic frame, it maintains the systolic frame and does not require readjustment. So in summary, if I want to adjust the systolic frame, I also must adjust the diastolic frame afterwards. If I want to adjust the diastolic frame, I can do that and not have any impact on the systolic frame. So these are some nuances about the program. Finally, if I were to choose this icon, this would begin a whole new trace sequence, which I'm not sure I want to do. Toggling between the right and left ventricle simply allows you to adjust the placement of in-systole and the end-diastolic frames on this graphic. If I want to export a clip, I go to MP4, which is now a more common format, and I would then save the video as video 1. And it then converts the AVI file to an MPEG-4 file. If you want to use an AVI file, you simply would do the same, and this would be an AVI file. Other icons, this is a screenshot. I'll take a screenshot of this. This represents, again, the text in the XML file that I would save. And finally, this icon saves a screenshot. Now there's another part of the analysis which also has been, that people have used and actually reported on, that when I do the analysis, I can click here, segmental analysis, and now I see these screens. This represents the strain graph for the ventricles. Here's displacement, velocity, and strain rate. I have not used these elements in our papers. This is an area of potential research for those who are interested in doing so. Once you've completed your TomTec analysis of the fetal heart and exported the XML file, the question is, how do you know what measurements are normal or abnormal? What I've done is created a calculator using gestational age as the independent variable. This is the calculator, this is the XML file, and this is the database, which I'll use in a few moments. So let's begin and see how we use this calculator. Number one, let's look at the features. The yellow cells are data that you enter by typing in the information. Here we have demographics, weeks and days for gestational age, the estimated fetal weight in grams, and the length and width of the four-chamber view that you measured before you entered the Speckle tracking analysis program. The orange cells will be populated from cells from the XML calculator, and I'll show you in a few moments. Once this data is entered, then all of these calculations are performed that include the size and shape of the four-chamber view, ventricular end diastolic measurements for the area, length, and width, the ventricular end diastolic ratios, ventricular sphericity index, ventricular global contractility, ventricular strain, ventricular left ventricular function, ventricular transverse width fractional shortening, the ventricular basal apical fractional shortening, and the ventricular annular plane systolic excursion. So all of these are computed from the measurements that you enter and represented in 3 columns: the value, the z-score, and this corresponding centile. So let's enter some data and see what we have. Okay, so these are the things you'd enter, the weight you'd obtain from your ultrasound machine, gestational age as well, and these would be from the linear measurements of the four-chamber view in diastole. Let's now go to the XML sheet. The beats per minute are listed here, so I would simply copy this from cell B13 and paste. To populate the ventricular measurements from the TomTec analysis, we scroll down to row number 66. I'm interested in column B, the measurements for the left ventricle, so I copy. And I'm going to paste special values. So I've populated this, and I will then do the same thing for the right ventricle from column F. Paste special values. We've now populated the calculator with the measurements, and here are the results showing the values, the z-scores, and the centiles. So once this is done, I can actually print this report if I wanted to by clicking File, Print, and the print, if you select Scale to Fit, you have the entire report printed on one page. This can be printed as a PDF or for your printer. For those of you interested in research, I've created a tab, it's called Vore Database, and what you observe is a column of data from the calculator listed like so. So what you'd simply do is copy cell B, copy, and this is your database. Paste special. Now why is this important? Because you're going to paste the values since the data in column B are all computed, and now we've populated the database with our first study. I'll just clean this up a bit, and we'll call this study number 1. After I'd finished with my first patient, the second patient, I would do the same thing. I would run the calculator, copy column B from that particular study, and simply paste special values. And I would just keep doing this for each of the studies that I was interested in. Paste special values. The reason for doing this is because if I want to do a statistical analysis on my data set, say for the left ventricle, I would simply copy these rows, copy, and I'd open up a new tab. I would then click this tab, paste special, and transpose. So now we have a column of data for each of the measurements that we have. Then you can run your statistical analysis. Once I've finished my calculations and exporting my data to a database, and I want to now take and clear the calculator. So simply what I do is I click Clear Data, and all the measurements and computations are removed, ready for your next patient. This is a case of pulmonary stenosis. I'm going to now quickly measure the length and the width of the 4-chamber view. Which is 41.57 and 37.4. I'm going to save this image. And now let's activate the speckle tracking. What I've done, I've already analyzed the heart using speckle tracking analysis, so I simply click on these 2 saved images and load the system. What I'd like to do is discuss what we see on the screen. Let's first look at the overall clip. This is the left atrium, left ventricle, right ventricle. As you observe the movement of the walls, what is striking about the movement of the right lateral wall and the interventricular septum of the right ventricle? You'll notice that there is a lot of movement of the septum towards the left side of the heart. This is atypical and abnormal. So again, look at the motion of the yellow dots. Also, there's an exaggeration of movement of the left ventricular septum and lateral wall. Let's look at the strain. And looking at this, we see there's some red components at the base and the apex suggesting potential abnormal strain. This is, of course, the vector analysis, which is visually nice, but doesn't really help us in a quantitative fashion. And again, here's the clip. And notice that the right ventricle seems to do a lot of rocking, but not a lot of inward squeezing. Now, this graphic, What we're going to do, because we've oriented the heart so that the septum of the left ventricle is here and the septum of the right ventricle is here, notice that there's a lot of movement of the left ventricular septum towards the center of the chamber, much more than we normally see in a normal situation. This is the right ventricle. The blue line represents the position of the segments that end diastole and the yellow at end systole. Notice that the segments move quite a bit towards the left side of the chest, towards the left ventricle, so this is exaggerated septal motion of the right ventricle. These are the corresponding measurements. This is the strain graph and the corresponding changes in the DA/DT. I've exported the XML file. We're now going to take and open up that file in the calculator and see what types of measurements that may be abnormal in this case of pulmonary stenosis. This is the calculator analysis for the fetus with pulmonary stenosis. I've entered in the data from the XML sheet, as well as the length and width of the four-chamber view, the gestational age, the estimated fetal weight, and the heartbeat. So let's examine now the output. What I've done for our discussion is I've pasted the graphic showing the movement of the segments. This is the end diastolic position, the green line, and the end systolic position, and then the movement and direction of the individual segments. So we'll use these graphics as we discuss what we observe in the output. I've also highlighted in yellow and orange those values that are less than the 10th percentile or greater than the 90th percentile, or in those ranges. If we look at the right ventricular area and the right ventricular length, we see that the area is at the 6th percentile and the length is the 10th percentile, and this is illustrated by this graphic. You'll see that this right ventricular chamber is much smaller than the left ventricle. If we examine the sphericity index for the right ventricular chamber, at the base we note the value is increased to above 99%. What this means is the base is more flattened compared to the length, whereas the mid-chamber, as you can see here, bulges, and that suggests that it's more globular shape in this portion of the chamber. If we go down to the contractility, the left ventricular fractional area change is quite increased. It has a Z-score of 32, and this is because of the hyperdynamic movement of the interventricular septum towards the center of the left ventricle. This is because this is being pushed over by the movement of the interventricular septum of the right ventricle. This is because of the pulmonary stenosis, and as the heart tries to eject blood out of the pulmonary artery, you get this abnormal motion of the septum affecting the left ventricular septum as well. If we examine global strain, we notice that the right ventricle has a value of 81.09%. That is in the high range of the abnormal. For example, any value above the 95th percentile for strain is considered abnormal, so this is coming close to that. However, the left ventricular strain has a minus 5.29 Z-score. That means it's hypercontractile. You can see here the length of the endocardium at end diastole is much larger than the endocardium at end systole. This is because, again, of the hyperdynamic movement of the interventricular septum on the left side, secondary to the right side of pathology. If we go down now and look at left ventricular function, we see that the ejection fraction has a Z-score of 4, and the output per kilogram is a Z-score of 1.54, so the 93rd percentile. So the ejection fraction, again, is because of the hyperdynamic movement of the interventricular septum. If we examine now ventricular transverse width fractional shortening, you'll see that it's normal for the right ventricle, even though you have this displacement of the septum towards the left. The transverse fractional shortening seems to be adequate. However, the right side is markedly increased with high Z-scores. That again is because of the hyperdynamic motion of the interventricular septum resulting from the pathology of the septum of the fetus with pulmonary stenosis. And finally, if we look at the annular plane systolic excursion, it is depressed for the right ventricular lateral wall. This is the movement of the base, where it is increased for the left ventricle. As you can see, this is a large increase here for the left ventricular lateral and septal walls. So this gives you an idea of what the measurements mean and how you would interpret them. And the graphic that we see here is very, very useful as we compare the values that we measure with what we observe in the segmental motion of the 24 segments in the right and left ventricles. In conclusion, I've demonstrated how to use the TomTec software using a specific program developed for the fetal heart. The program provides a number of fetal measurements that can be used to evaluate the size, shape, and function of the ventricles. Using equations for the mean and standard deviation from our prior publications, I have created a calculator that can be used to compute z-scores and centiles for a number of cardiac measurements. I am happy to share the calculator with you if you would like to use the data from our studies. To do so, just simply send me an email at grdevore@gmail.com. Thank you for your attention.